Nice to meet you. My name is Eunseok Kim. I'm in Department of Acupuncture and Maxillofacial Medicine, Busan National University as Assistant Professor. Today, I'm going to introduce RCT I performed in 2019 concerning a thread embedding acupuncture for treating chronic neck pain. This study was designed to test the hypothesis that a 4-week thread embedding acupuncture treatment would improve pain and disability among patients with chronic neck pain as compared with physical therapy. Let's start with the photos of thread embedding acupuncture. Let me call it a TEA. You will see the two types of TEA device. The photos on your left present the polydioxanone TEA, which is currently used in Korea. The suture material is polydioxanone, and the thread is folded in half, and one side is inserted in the needle, and the other side is fixed to the outside of needle by the anchor. There is also another type of TEA, which is generally used in China. The device consists of internal stylet and external cannula, and the suture material is catgut, chromic catgut, polyglycolide lactide, and so on. It is generally thought that the treatment component contributing to the effect of a TEA consists of acupuncture or dry needling itself and a continuous stimulating effect by threads embedded. When it comes to clinical use of TEA, they usually use the TEA treatment for the purpose of stimulating acupuncture points or eliciting local histological effect. So, for example, there was RCT applied catgut thread embedding therapy on these acupoints in the treatment of a patient with allergic rhinitis. A local histological effect of TEA is that TEA may have played a role in tightening lax skin and reform the soft tissue as long-lasting stimulator for collagen fiber formation. In addition, when a TEA is used in beauty treatment, facial lifting is generally being performed using TEA composed of an anchor and a hook-type suture, as you can see. From this slide onward, we'll look into the study design and results. I performed an access-blinded, randomized controlled clinical trial to evaluate the effectiveness and safety of TEA treatment compared to physical therapy in the treatment of patients with chronic neck pain. A total of 128 patients diagnosed with chronic neck pain were randomly assigned in a 1-to-1 ratio to either the TEA or physical therapy group. The TEA group received a total of 4 TEA treatment, while the physical therapy group received a total of 8 physical therapy treatment over 4 weeks. The primary endpoint was 9 weeks, and we performed the third follow-up at 13 weeks. So the period of follow-up was about 3 months. Also, radiography and blood tests were conducted at screening visit. The research clinicians made the final diagnosis of the illness at the last stage of the screening process and determined the subject eligibility based on the inclusion and exclusion criteria as follows. Exclusion criteria, it says a subject is aged between 19 and 65 years old, and apparently is a chronic, so they have suffered from neck pain for over 3 months and scores more than 40 millimeter on the visual analog scale at the time of screening, and diagnosed with this chronic neck pain based on image examination, history taking, physical and medical examination. We specifically try to exclude a cervical radiculopathy, myelopathy, and severe major cervical disorders. And other exclusion criteria are as follows. So let me show you the TA treatment. A total of 4 TA treatments were administered once a week for 4 weeks, and the TA of 29 gauge in a diameter and a 30 or 40 millimeter in length was selectively used. The practitioner inserted the TA and immediately withdrew it without further stimulation. And I set up the acupoint spool, and the practitioner selected 4 to 8 insertion points per side from acupoint spool according to the subject symptom. Let me explain the background on acupoint spool. First, I considered nerve entrapment, which is one of the cause of chronic neck pain and muscle spasm and ischemic pain caused by it. And considering the local and segmental effect of acupuncture, the acupoint pool was constructed. Let's talk about the TA points based on accessory nerve entrainment. Accessory nerve arises from the upper cervical spine and goes up the foramen magnum and descend again, pass through the SCM and innervated to the upper trapezius. From this point of view, BL10 or the XB2 C3 level in the proximal part of the accessory nerve was selected. When needling TE16, I applied the oblique superior insertion so that polydioxane thread was embedded in clavicular head part of the SCM, known as the main muscle that entraps the accessory nerve. Finally, GB21, the main acupuncture point in the upper trapezius muscle innervated by the accessory nerve was selected. Let me show you the demonstration for TA treatment on these points. The first one is BL10, the second one is T16, and you're seeing the GB21. And dorsal scapular nerve arises from the brachial plexus and usually from plexus root of the cervical nerve C5. Once the nerve leaves C5, it commonly pierces the middle scalene muscle and continues deep to the liberator scapular and rhomboid muscle. From this point of view, XB2 in the proximal XB2 C5 level in the proximal part of the dorsal scapular nerve was selected. When needling LI17 located posterior to the border of SCM, I inserted the needle oblique inferiorly along the scalene muscle. SI14 was also selected because the pain between the medial border of scapula and thoracic vertebra is also caused by the referred pain by the trigger point of the levator scapular muscle. You will see the demonstration for TA treatment on these points. It will include the IC point around the medial border of the scapula. This one is EXB2 level C5. and I insert the TA needle along the scaling muscle. This one is for SI14. These are archy points on the rhomboid muscle. And anticipating the local effect of acupuncture, GB20 was also selected as an acupoint to stimulate the suboccipital muscle. And let's watch the video again as a way to do the procedure. In addition, XB2 acupoints are located at the level of C3 to the T3 level was selected to derive the segmental effect of acupuncture. I'm performing the TA treatment on a cervical thoracic junction for EXP2. And the physical therapy include ICT and HAPEC. Total of 8 physical therapy treatment was administered twice a week for 4 weeks. PT group received heat therapy using HAPEC and interferential current therapy, ICT. An ICT pad was attached to the 4 points of the neck pain area, and HAPEC was applied to the neck region at the same time for about 15 minutes per session. MPDS is a questionnaire developed to evaluate the pain and disability in various activities of daily living based on visual analog scale. So I adopted the MPDS as a primary outcome measure. As you can see, I also adopted a clinically important difference. It's a minimally clinically important difference. MCID is a minimum difference that a patient can feel to be clinically effective. And MCID for MPDS is known to be greater than 11.5. So in this study, the clinical relevance was assessed by comparing the percentage of subject indicating an improvement of more than 11.5 points, which is an MCID of more than 30%, moderate CID of more than 50% substantial improvement, respectively, between the two groups. And the rest of secondary outcome measures are cervical spinal angle, BDI and BAI is for the depressive disorder and anxiety disorder, respectively, and a quality of life is an EQ5D, and a patient global impression of change and adverse effect. Let me show you the result. This is study flow. And among the 128 eligible patients, 116 completed the study, while the 12 dropped out, 8 in the TA group and 4 in the PT group. 8 cases who withdrew consent for personal reasons, and 4 cases discontinued due to the adverse events. In the demographic characteristic and outcome variables at baseline, no significant differences were found between the two groups. And the TEA group showed a significant improvement in MPDS compared to the physical therapy group at 5, 9, and 13 weeks. Specifically, the difference between the two groups in MPDS scores tend to increase from 5 weeks to 9 weeks, and also significant even up to 13 weeks. Considering the chronic pain tend to be stubborn, it is noteworthy that the difference in the MPDS scores between the two groups remained at around 15 points in MPDS at all follow-up assessment. In RM ANOVA analogizing change over time, MPDS showed a significant group by time interaction effect. Also, significant improvement in BDI, BAI, and EQ5D were observed in the TEA group compared with the physical therapy group. These results suggest that the TEA may be effective in improving psychological distress and quality of life of chronic neck pain patients. However, in cervical spinal angle, there was no significant differences between the two groups before and after intervention. The proportion of patients with decreased MPDS scores of more than minimal CID, 30% and 50%, was significantly higher in the TEA group compared with the PT group. Therefore, TEA treatment is not only statistically more effective in the treatment of a chronic neck pain patient than the physical therapy, but also clinically meaningful. Additionally, the percentage of subjects who answered improved in TEA group was 96.5% at 9 weeks and 98.2% at 13 weeks. This percentage were significantly higher than those in the PT group. Additionally, among 1,082 visitations, 22 mild adverse events and 4 severe adverse events were reported. Among 22 mild adverse events, 14 adverse events were related to the TEA, 2 adverse events were related to the physical therapy, and 6 adverse events were not associated with the intervention. Among 14 adverse events related to the TEA, adverse event from 2 to 7 days were 9, and adverse event for more than 7 days were 5. Bruise was the most common discomfort, whereas the others were stiffness in the neck region, pain, edema, pricking, and irritation caused by the thread. Among the 4 severe adverse events, 1 severe adverse event was related to the TEA, while the other 3 severe events were not related to the intervention. Despite of this result, there was some limitations of this study. As you can see, the practitioners and subject could not blinded, so non-specific effect, such as treatment expectation or placebo, could not be excluded. And the possibility that this non-specific effect had a more favorable effect on the TEA group was not completely excluded. A patient in the TEA group still maintained MPDS scores between about 30 to 35. And follow-up period of 13 weeks was not enough to measure the long-term effect of a TEA. And the pneumothorax, which is a severe adverse event, occurred due to the practitioner's error. To my knowledge, this is the first confirmatory RCT comparing the effect of TEA treatment with those of physical therapy. I adopted a relatively pragmatic study intervention to be able to select individualized points according to the patient's symptom. The research clinician made a final diagnosis of illness at the last stage of the screening process and determined the subject eligibility. It also presents an example of effective TA treatment modality, such as acupoint spool, insertion method, number of sessions, and frequency of TA treatment. It is considered that appropriate outcome measures were used in this study. MPTS, the primary outcome measure, provides a responsive and comprehensive measure for the multidimensional nature of chronic neck pain. I also adopted the psychological measurements based on the fact that psychological factors are important prognostic factor of CNP. In conclusion, for patients with CNP, TA treatment was found to be more effective than physical therapy treatment for improving their pain and dysfunction, quality of life, and psychological distress. Despite some post-treatment discomfort, TA treatment can be considered as a useful treatment method for patients with chronic neck pain. Thank you for listening.